Boys with delayed puberty. Professor of Pediatric Endocrinology, Isfahan University of Medical Sciences. MEPO. Delay in onset of secondary sexual development by ages 12-13. Delayed puberty. Girls. Delay in onset of secondary sexual development by ages 12-13. Primary amenorrhea at 15.5 to 16 years. Boys. Delay in onset of secondary sexual development by age 14 years. Mean duration from the onset of puberty to onset of menarche is 2.4 plus minus 1.1 years. Detained puberty. Puberty has started but has not concluded after 5 years. Detained puberty. A boy who has not completed his secondary sexual development, 4.5 years from the onset of puberty T2. A girl who does not experience menses within 5 years from the onset of puberty B2. Hypogonadotropin, hypogonadism. Delayed puberty types. Constitutional. Hypogonadism. Hypogonadism. Medical history. 14-year-old boy. Shortest in his class. No problem at school. Always looks small. What do you ask him? No chronic disease. Normal sense of smell. Sexual function and patterns of body hair. Known testicular abnormalities. Social and family history. Student. Non-smoker. No siblings. Mother has arthritis. Further did not grow till he entered college. What's important in physical examination? No dysmorphic features CVS, RISP, Abbott exam are normal BP equals 110/76. Physical examination. No dysmorphic features. CVS, RISP, Abbott exam are normal. BP equals 110/76. Height equals 135 centimeters. Score equals -3.9. Weight equals 30 kilograms. Arm span, height span equals 2 centimeters. Growth velocity equals 5 centimeters/year. Physical examination. Arm span, height span equals 2 centimeters. Growth velocity equals 5 centimeters/year. Normal testicular consistency. No pubic and axillary hair. No gynecomastia. Testicular volume equals 2.5 milliliters. Testicular length equals 1.5 centimeters. Penis length equals 6 centimeters. Normal testicular consistency. No pubic and axillary hair. No gynecomastia. What's your differential diagnosis? What's your investigation? Hormonal and biochemical study. Normal BUN and DSR. Normal T4 and TSH. Low IGF-1 and IGF-3 for age. Normal IGF-1 and IGF-3 for BA. Normal GH stimulation test. Hormonal and biochemical study. Testosterone equals 0.15 nanograms, ml. Celiac test equals OK. Cortisol levels equals OK. HNA-H test shows no response. Low gonadotropin. Normal prolactin. Imaging. BA equals 11.5 years. MRI equals normal. What's your treatment? Vitamin A equals 6,000 U/week for 3 months. We prescribed oxandrolone for 6 months. Zinc 12.5 mg/day. Iron 12 mg/day for 3 mo. Vitamin A equals 6,000 U/week for 3 months. but testicular volume and testicular length did not change. Diagnosis? Any comments? Because of not response to treatment. We prescribe testosterone 50 mg every month for 3 months. Letrozole 2.5 mg/day. Testosterone level was 0.8 nanograms/ml. Testicular volume equals 5 milliliters. 6 months after stopping testosterone, testosterone level was 0.8 nanograms/ml. Testicular volume equals 5 milliliters. Testicular length equals 3 centimeters. Diagnosis. Constitutional delayed puberty. Discussion. CDGP is not a medical disorder, but a temporary condition. If treatment is necessary for a child, it must be emphasized that they are normal. Their body clock for puberty has just started later than their friends. CDGP is a common condition. Boys greater than girls. Boys look young. Normal physical examination. No evidence for systemic disease. No evidence for hormonal dysfunction. Usually normal nutrition. CDGP. Short stature. Height at or below 3rd percentile, CDGP. HA less than CABA less than CAGV equals N. BA equals HA P equals B dot A. P 8. TH. HA less than CA. P. P equals B dot A. 8. 8. 8. 8. 8. 8. 8. BA less than CA. 8. 8. 8. 8. 8. BA equals HA. 8. 8. 8. 8. 8. 8. 8. 8. GV equals N. 8. CDGP delayed puberty and pubertal growth spurt. Family history of delayed puberty. CDGP normal growth rate for bone age. Delay bone age 1-3 years. Normal height for bone age. Height reach within the lower part of midparental target height. Adult height. Height reach within the lower part of midparental target height. HA less than CABA less than CAGV equals NBA equals HA P equals B dot A. P 8. TH. HA less than CA. P. P equals B dot A. 8. 8. 8. 8. 8. 8. 8. BA less than CA. 8. 8. 8. 8. 8. BA equals HA. 8. 8. 8. 8. 8. 8. 8. 8. GV equals N. 8. Height deficit at onset of puberty. Height deficit at onset of puberty. CDGP. IGFI is normal for BA. Delayed adrenarche. Iron and zinc deficiency. Nutrition. CDGM. Decreased vitamins A and D. Iron and zinc deficiency. Diagnostic approach to delayed puberty. There is an overlap in physical and labs findings. Differentiation between HH and CDP is very difficult because There is an overlap in physical and labs findings. Growth chart. Patients with HH have normal height in early or mid-adolescence. Patients with CDP are short. Initial approach bone age. X-ray of the left hand and wrist to evaluate bone age. The onset of puberty correlates with BA equals 11 to 13 years in girls. The onset of puberty correlates with BA equals 11 to 13 years in girls. BA equals 12 to 14 in boys. Patients with CDP usually continue pubertal development. At bone age. 11 to 13 years in girls. 12 to 14 years in boys. Patients with CDP usually continue pubertal development, if elevated in patients who are apparently healthy. Initial approach. In patients who are apparently healthy. Initial assessment of LH and FSH. If elevated. Hypogonadotropic hypogonadism. Differential diagnosis. If low. Hypogo. If gonadotropins low or lower limit of normal. DDX. Constitutional delayed puberty. Brain tumor. Hypopituitarism. Hypothyroidism. Hyperprolactinemia, if gonadotropins low or lower limit of normal. Malnutrition. Exercise intensity. Use of medications. Chronic disease. HA less than CA, BA less than CA, GV equals N. BA equals HA, P equals B dot A. P8. TH. HA less than CA. P equals B dot A. 8. BA less than CA. 8. BA equals HA. 8. GV equals N. 8. Hypogonadotropin hypogonadism. Differential diagnosis. Hypogonadotropin hypogonadism. Adrenarche is at the normal age. Higher YAS than CDP. Isolated gonadotropin deficiency. After the age of 18. Absence of first signs of puberty. Failure of a rise in gonadotropins. Failure of a rise in gonadal steroids. Isolated gonadotropin deficiency. Serial height and testicular measurements made over 1 to 2 years will help clarify the diagnosis. Isolated gonadotropin deficiency. As no single test can distinguish between these two disorders, so we should rely on clinical clues and the natural evolution over time. Pituitary failure. Diagnostic evaluation. Morning serum testosterone greater than 0.2 nanograms/ml. Predicted increase in testicular size to greater than 4 milliliters within 12 mo in 77% in boys. 15 mo in 100% of boys. In boys with less than 0.2 nanograms/ml. 12.5% of boys will have puberty within 12 mo. Treatment. Treatment watchful waiting includes periodic evaluation of testes and testosterone every 6 mo. Reassurance. Psychological counseling. Assurance to family. Treatment. Testosterone. Oxandrolone. GH. Trace elements. Treatment in BA less than 10 years. Has the risk of accelerated BA and short adult height. Testosterone therapy may be started as early as a bone age of 12 to 13 years to decrease the psychological disturbance. Testosterone therapy. Testicular enlargement. At BA equals 12, CA equals 14 to 14.5 years. 50 mg once a month for 3 to 6 months. 6 months later. It is spontaneous pubertal development if testicular enlargement. Increasing testosterone greater than 50 nanograms/dl. Management. 6 to 12 months after completing the first course of therapy. If testosterone less than 50 nanograms/dl. Not testicular enlargement. Give another course for 3 to 6 months. Management. Treatment should not continue more than 2 courses. To differentiate CDP from permanent DP. Constitutional delayed puberty. After 2 courses. 6 to 12 months after completing the second course of therapy. 8 am serum testosterone 50 nanograms/dl. ppv 100%, PNV 59%. LH peak 14 IU 3 hours after triptorelin. ppv 100%, PNV 72%. DX equals CDGP, aromatase inhibitors, alone or in combination with RHGH. Growth hormone therapy. The value is controversial. Oxandrolone 1.25 to 2.5 mg/day 0.05 mg/kg daily for 1 year. Pediatrics. 1995 December, 96-6, 1095 to 100, oxandrolone after oxandrolone withdrawal. Growth-promoting effects is related to mild androgenic effects of it. After oxandrolone withdrawal. Increase in total serum testosterone. Progress in puberty. Any question? NRA. Decapeptyl. 0.1 mg/m2sc. 1 to 20 grams/kg, 500 grams. 100 grams/m2. NRA after 4 hours. LH and FSH should be measured. LH greater than 8 μs/ml, in favor CDGP. LH assay by commercial chemiluminescent kit. All of these patients entered spontaneous puberty within 1 year. Constitutional delay puberty. First signs of secondary sexual development occur within 1 year after. LH rises to pubertal levels after administration of 100 grams GnRH. Subcutaneous GnRH agonist. After GN and sex steroid begin to increase spontaneously above prepubertal values. An 8 am serum testosterone 20 nanograms/dl puberty develop within 12 to 15 months. Use of GnRH agonist and human chorionic gonadotrophin tests for differentiating constitutional delayed puberty from gonadotrophin deficiency in boys. The GnRH agonist test and the repeated injection HCG test are reliable diagnostic tools for differentiating CDP from GD in boys. Clinical Endocrinology, 2002, 56, 603 to 607. Synthetic LHRH. 0.1 mg/m2 bolus blood samples for of LH, FSH and testosterone levels were drawn prior to injection and 30 and 60. LH greater than 7.5 IU/L usually precedes the first physical sign of sexual maturation by less than 1 year. Bizarrelin test. LH, FSH at 0 and 4 hours were measured. Low LH response to bizarrelin, HH could be diagnosed with a sensitivity of 100% and a specificity of 96%. Journal of Pediatrics 2006. LH less than 5 HH, LH greater than 5 CDGP. Kalman. CD puberty. Kalman. Kalman. Pituitary failure. LHRH test time, min, minus 15 15 30 45 60 90 120 FSH μ/ml 4.85.16.06.9 15 30 45 60 90 120 FSH μ/ml 4.8 5.1 6.0 6.9 8.5 10.1 12.5 14.1 LH 1.3 2.6 5.0 8.6 10.7 10.8 11.9 HGH 0.625 nanograms/ml TSH:3.35 U/ml cortisol 19 micrograms/dl prolactin: 3.66 laboratory assessment HCG stimulation test 3000 units/m2 per injection 1 to 3 injections daily or on alternate days. Testosterone should be obtained within 24 hours of the last injection. Testosterone levels greater than 170 nanograms/dl after a single injection. 200 nanograms/dl on day 3. 300 nanograms/dl on day 5. Indicates normal testicular function. Pituitary failure. Prader-Willi syndrome. Diagnostic evaluation. BA equals HRCA constitutional delay puberty. Late onset growth failure especially with DI. SNES tumor, testicular volume greater than 3 to 4 milliliters, longitudinal measurement 2.5 centimeters. Pubertal development. Testicular volume greater than 3 to 4 milliliters. Longitudinal measurement 2.5 centimeters. Serum testosterone greater than 0.5 nanograms per milliliter. Management if the LH level rises more than 2.5 Sd above the mean value. Testosterone level decreases below the normal range for age. We think to HH. Birth, 1.73 years, 1.335 years, 1.17 years, 1.0. Upper to lower segment. The upper segment to lower segment ratio. Birth, 1.7. 3 years, 1.33. 5 years, 1.17. 10 years, 1.0.